The next item of business today is a member's business debate on motion number 4623 in the name of Helen Eadie on clinical standards for cardiac rehabilitation. This debate will be concluded without any questions being put. And with those members who wish to speak in the debate, please press the request to speak buttons now or as soon as possible. I now call on Helen Eadie. 7 minutes, please, Ms. Eadie.
Thank you very much, Presiding Officer, and I would like to say thank you to all my colleagues in the Scottish Parliament and to yourself for enabling me to bring to the Parliament this afternoon a debate and a subject, a topic which I'm very enthusiastic about myself. I think it's very important and offer it to colleagues for their support. Modern cardiac rehabilitation is menu-based and patient-centred and provides a pathway from diagnosis to long-term management while meeting patients' physical, psychological and social needs. It reduces all-cause mortality by up to 26% and cardiac mortality by up to 36%, while reducing unplanned hospital admissions by up to 56%. As members may be aware, I convene the cross-party group for heart disease and stroke and have heard firsthand from patients and health professionals how popular and important rehab can be in aiding recovery from heart conditions. The British Association for Cardiac Prevention and Rehabilitation, BACPR for short, presented on their standards at our last meeting in December and made a compelling case for the extension of cardiac rehabilitation to every heart patient who needs it. BACPR, as well as British Heart Foundation Scotland and Chest, Heart and Stroke Scotland, want assessment for cardiac rehab to be mandatory for every heart patient. This would cut hospital readmissions as well as unnecessary primary care appointments. Cardiac rehab is highly cost-effective, especially when compared to surgical interventions. In my constituency, I have been fortunate enough to visit a cardiac rehab class, which is part of BHF's Hearty Lives programme. This project allowed the 5 cardiac rehab service to increase capacity by offering a new programmes in different settings, including a community evening class, and as a result saw referrals double. The programme has now been mainstreamed, and I hope other NHS board areas may consider what lessons can be learned from this kind of approach. The National Health Service Quality Improvement Standards, Clinical Standards for Heart Disease from 2010 mandated an assessment for cardiac rehabilitation for all patients with the most common heart conditions. The Government's Better Heart Disease and Stroke Care Action Plan of 2009 also indicated that boards should regard cardiac rehab as a priority. Referrals for rehab have improved since these documents were published, but not quickly enough, especially for long-term heart conditions like heart failure and angina. This is possibly because much of the published evidence on cardiac rehab, at least in terms of the reductions in premature mortality, focuses on the benefits for acute conditions, such as heart attack and bypass patients. However, there is a growing body of evidence that shows that cardiac rehab for heart failure patients has significant benefits in terms of reductions in unnecessary hospital readmissions and, as such, is a highly cost-effective treatment for these patients. Indeed, a small study from Australia that was discussed at the cross-party group compared hospitalisation rates for 2 groups of heart failure patients, one of whom had access to rehab once a week and one which had no such access. The group which received cardiac rehabilitation spent, on average, 9.36 days a year fewer in hospital each year than those who did not receive it. The authors calculated that for every £1 Australian spent on rehab, 11.50 Australian dollars was saved through reduced costs of rehospitalisation. I understand that the cardiac rehab team in Ayrshire and Arran is looking to replicate this study using data from that area. These are estimated to be 70,000 people in Scotland living with heart failure. The figures from ISD Scotland suggest only 3% of these patients are being referred for rehab. How much money could be saved if, as a result of referrals to rehab for these patients? The NHS saved £11 for every pound it spent. I urge the Minister to take the opportunity in responding to this debate to consider what more the Government can do to improve the provision of these crucial services, especially for long-term cardiac conditions such as heart failure. In particular, I urge him to consider what steps are needed to develop a sustainable audit of the provision of rehab services by NHS board area and by specific heart condition, as well as what additional policies should be employed to drive assessments for cardiac rehab across the country. The briefing provided by the Scottish Campaign for Cardiac Rehab suggests that a heat target for referrals to rehab for all heart patients should be considered by the Government, and I urge the Minister to take that on board. I hope that politicians of all parties, the main charities who have campaigned for years for improvements in these services, such as British Heart Foundation Scotland and Chest, Heart and Stroke Scotland, NHS boards and the health professionals on the ground can work together in the year ahead and ensure that every heart patient is referred for cardiac rehabilitation as a matter of course. And I thank you, Presiding Officer, for the chance to contribute. Thank you.
Many thanks. Now call on Dave Thompson to be followed by Jackie Bailey. 4 minutes or thereby, please.
Yeah. Well, thank you, Presiding Officer, and I would like to thank Helen Eadie for securing this debate. It's a very important issue indeed. As Vice-Convener of the cross-party group for heart disease and stroke, I have also had the privilege of hearing on many occasions the substantial benefits that arise from provision of cardiac rehab for all heart patients. And I also have personal experience of how effective cardiac rehab can be following open heart surgery in 2006. Last year, the group heard a presentation from the British Association of Cardiac Rehab, BACPR, on the new standards that Helen Eadie's motion focuses on. Now, these standards include the following goal, and I quote, ensuring referral of all eligible patients by cardiologists and/or specialist cardiovascular healthcare physicians to a prevention and rehabilitation programme as a standard, brackets not optional, policy that is held in the same regard as the prescribing of cardioprotective medications. Now, I think this is a very worthy aspiration towards which we should all be working. The evidence base for the effectiveness of cardiac rehab is overwhelming, as Helen Eadie has already said. It is very cost-effective, especially compared to surgical interventions for cardiac conditions, and it reduces premature mortality and reduces hospital readmissions. The SIGN guidelines of 2002 stated that it should be provided for all heart attack and bypass patients, and that all patients with heart failure and stable angina with limiting symptoms should be assessed for it. And these were all Grade A recommendations, the highest category. The Government's 2009 Better Heart Disease and Stroke Action Plan also reiterated that health boards should recognise the importance of providing rehab to all heart patients. As a result of this focus, NHS Scotland has made good progress in improving the provision of cardiac rehab over the last few years, especially in terms of acute heart conditions, with the figures showing that 75% of heart attack patients and 68% of heart bypass patients were referred for cardiac rehab nationally. However, some health board areas still appear to be underperforming in this area. In NHS Highland, for example, just over 40% of eligible heart attack patients were referred for cardiac rehab. Clearly, providing these services over a large rural area is a challenge, but this shows there is still some way to go. As is noted in the motion, there are particular issues around the provision of rehab for the longer-term conditions right across Scotland, especially for heart failure and angina. In NHS Highland, again, for example, only 3% of eligible heart failure patients appear to have been referred for rehab in 2011. And nationally, I believe the proportion of referrals of these patients is no better than that. British Heart Foundation Scotland, Chest, Heart and Stroke Scotland, who have led the campaigning work in this area over the last few years, are now saying that they believe the time is right for the Scottish Government to consider what further steps it can take to drive improvements. And I agree. Specifically, they feel that ministers should consider if assessment for cardiac rehab would be a suitable candidate for a new heat target, as Helen Eadie again has also already said. I'm aware that ministers share the aspiration of the BACPR, as well as BHFS and CHSS, that referral to cardiac rehab should be a mandatory policy for all heart patients, just like it is for many of the pharmaceutical treatments for cardiac disease. I would, therefore, be interested to hear whether the Minister believes that referrals to cardiac rehab as a heat target, as the charities are proposing, would be something that his officials could examine.
Many thanks. Now call on Jackie Bailey to be followed by Dennis Robertson.
Thank you very much, Presiding Officer, and let me join with others in the Chamber in congratulating Helen Eadie on securing this debate. I know Helen is very committed to this issue and, as she herself has said, has worked extremely hard over the years as the convener of the cross-party group on heart disease and stroke to influence the Parliament and the Government's thinking. And today she brings the campaign for cardiac rehabilitation to the Parliament chamber. The campaign, which, as we've heard, is a collaboration between a number of significant voluntary organisations, such as the British Heart Foundation and others already mentioned. But their aim is to ensure that every heart patient who is suitable is given access to a rehabilitation programme. Now that makes sense because you do get better quicker. It can save and transform lives. They also argue that patients should be offered alternative methods of rehabilitation, whether that's home-based or community-based, rather than hospital programmes if people perhaps aren't able to take part. And that is important to overcome barriers to participation. But that also applies to people living in deprived or remote and rural communities who may struggle to access services. And, I was struck by Dave Thompson's description of some of the inequity of service in his own area. And the campaign also calls for minimum standards and monitoring, much of which has already been touched on. But we know that adopting this approach to cardiac rehabilitation can transform lives, but at the same time, it can save money, which frankly in times of austerity is no bad thing. I understand from the campaign briefing that rehabilitation has reduced death from heart disease by more than a third in just over 10 years. Now that is a considerable achievement. They also point out that it can help to prevent the need for much more costly treatment, a heart bypass costing in excess of £5,000, rehab costing less than £2,000. The figures are there and make a great deal of interesting reading. And of course, cardiac rehabilitation has cut readmissions to hospital by as much as 30%. So by whatever measure you consider this, it is clearly worth doing. Now, I recall visiting a cardiac rehabilitation group in Dumbarton. They had nothing but praise for the staff that worked with them, like the physios and the nurses. There were a couple of grumbles about what the physios made them do, but by and large, everybody there recognised that they were very fortunate to have good access to an excellent rehab service. But that's not the case everywhere. But what I frankly couldn't get over was here was a bunch of people that I can only describe as being full of life. They may have all had heart attacks, but that wasn't going to stop them. They were very much looking forward and very much having fun and enjoyment as they were doing that. It was a group that was filled with laughter. And Presiding Officer, I want that quality of cardiac rehabilitation, not just in Dumbarton, but absolutely for everyone in Scotland. We need to take the examples of good practice. The government needs to spread them to every health board in every corner of the country. But I do want to congratulate the NHS on what has already been achieved. The action plan is a positive move forward. Staff have embraced that in many areas and have been working to implement that. And we see that in mortality rates from heart disease falling by 60%. But we know we can do more, and we can accelerate the pace of change. And it isn't often that we in this chamber all sing from the same hymn sheet, but we're doing that today, perhaps asking the government to consider a heat target, to accelerate the pace of change, to ensure that monitoring is in place, so that actually, and I hope the Minister will tell us this today, that we ensure the aims of the campaign will actually see the improvement of cardiac rehabilitation services, not just in one or two areas, but indeed right the way across the country. Thank you, Presiding Officer.
Thank you. I'm now calling Dennis Robertson to be followed by Jackson Carlo. Around 4 minutes, please.
Thank you, Presiding Officer. Can I, like others, again congratulate Helen Eadie for bringing this debate to the Chamber. I too, Presiding Officer, are a member of the Heart and Stroke cross-party group in this Parliament. It's not often, Presiding Officer, you'll hear me say that I'll sing the same tune as Jackie Baillie, despite whether it's a song sheet, hymn sheet or whatever. But Jackie Baillie makes very good sense of what she's saying in regard to preventative spend. Helen Eadie mentioned the 1 in $11 Australian dollars, the payback. Presiding Officer, it's much more important than that. It's about saving lives. It's about enhancing life. It's about ensuring that when rehab is given, people can generally lead, more often than not, a normal life. And that's the important factor. And the government, I am sure, will not miss the fact that it is cost effective by providing the appropriate rehabilitation, whether it be at hospital, community or domiciliary based. And certainly for our remote and rural areas, domiciliary and community is much preferred, as Dave Thompson, I think, alluded to. The percentage of people actually receiving rehabilitation, Presiding Officer, is too low. It's far too low. And we know that people themselves have a role to play in this. Diet is important, exercise is important, but structured, formal rehabilitation is by far the best way of saving lives. Presiding Officer, we need to congratulate all the charities involved. We've heard about the British Heart Foundation Scotland, Chest and Heart Stroke Scotland as well. But there are many other local charities as well trying to assist and provide good guidance and peer support for people with heart conditions. Helen Eadie mentioned the psychological aspect of people and families coping with heart conditions. Presiding Officer, I believe that there is sufficient evidence for the government to take action with regard to appropriate rehab for our patients in Scotland. Thank you.
Thank you very much. Now call on Jackson Carlo, after which we'll move to the Minister.
Thank you very much, Deputy Presiding Officer. You know, the distance between Fife and Troon, where Helen Eadie and I respectively live, is probably as great as the distance between Helen Eadie and I politically on almost every issue. But I have never, in my time dealing with Mrs Eadie, thought her anything other than enormously big-hearted. And as the convener of the Heart, Disease and Chest cross-party group, her commitment to this issue has been sustained over a very considerable period of time. And so I too congratulate her on the motion she's brought before Parliament today. I might express the view that it would have been to the benefit of more members to have heard some of what Mrs Eadie had to say and has been said subsequently. And I hope, since some of them may very one day benefit from the work and effort that the cross-party group and the British Heart Foundation and all the other campaigning groups are doing on this issue, to be a little bit better informed themselves on the issues at hand. My own contribution can be relatively brief because so many of the points have in fact now been made. And in essence, we all celebrate advances in healthcare as they are made. The establishment of the National Health Service after the war essentially brought an equality of access to everybody within the United Kingdom to healthcare. And it's interesting, in our generation, there are two kind of competing challenges. One is the enormous responsibility that there is falling on the health service to cope with our emerging lifestyle conditions and an ageing population. But the second is the way that we actually respond to the extraordinary advances that are actually being made in healthcare and the consequences and responsibilities that fall from that. Now, got to find a way to bring him in sometimes into debates. Michael Forsyth established when he was the Secretary of State a material shift in Scottish cardiac care in the mid-1990s. And that was, it may have been Michael, but it was in fact a change which enjoyed cross-party support at the time. Even to those who are not his natural admirers, Voldemort has his redeeming qualities. And 15 years later, we are able to see a 60% fall in mortality from cardiac incidents. Now, I suppose you could argue from the National Health Service's point of view, that's not a financial success. They may actually have taken the view, not as individuals, but from a bottom line, that if people weren't there, they weren't representing an ongoing cost to the National Health Service. And it is actually in celebrating that significant reduction in mortality that the responsibility emerges, because it is thereafter, what do we do to provide cardiac rehabilitation to those whose lives have been saved? And there's no disputing or concern in terms of principle or understanding that we have to make advance in that field. But when we look at the hard facts, we have to say that although there is a very considerable referral for cardiac rehabilitation amongst those who have had heart bypass operations, albeit less than still than the minimum we might wish, there is thereafter an underperformance across health boards in Scotland and a very considerable underperformance from where we are today and where we need to be in terms of affording a universality of access to cardiac rehabilitation. And it is tragic in a way if we have saved lives but have left people with a deteriorating lifestyle thereafter because we aren't able to offer them that support, advice, education and subsequent intervention to ensure that the life that we have saved is a life that is thereafter meaningful. And it is sometimes difficult within such a huge institution as the Health Service to ensure that these cross benefits are achieved. So I too support the campaign that's been made, support the essence of Mr Eadie's motion and look forward to hearing whether the Minister himself now feels that in order to give it that impetus, it perhaps does need a heat target to ensure that material progress is made.
Many thanks. I now call on Minister Michael Matheson to close on behalf of the Government. 7 minutes, please.
Thank you, Presiding Officer. Can I begin, like others, in congratulate Helen Eadie in securing time for this debate, what I think has actually been a very, although short debate, very interesting debate and very focused on a couple of very specific issues as well. Although it wasn't a debate, I was anticipating the possibility of a Robertson-Bailey duet or the spectre of Michael Forsyth to be brought into it, but I'm more than happy to acknowledge the work that Michael Forsyth undertook when he was in a position to do so. I'll give way to Miss Bailey.
Bailey.
If Michael Forsyth is Voldemort, would you be Harry Potter?
Minister.
Well, I would obviously have to get the glasses, but would you call it? I'll take that as a compliment, actually, Presiding Officer. Heart disease has been a clinical priority for the Scottish Government and for NHS Scotland for over 15 years now. And over this period, thanks to the dedication of the staff within the NHS, we have achieved a dramatic 60% decrease in the number of premature deaths from heart disease. And I'm sure everyone would agree that this has been achieved through the fantastic efforts of our NHS staff. But Jackson Carlaw is correct in that this in itself brings an additional challenge, because as more people survive heart attacks and live with heart disease, they need access to high-quality rehabilitation and support. These needs have to be recognised and have been within the NHS, as well as by organisations such as Chest, Heart and Stroke Scotland and the British Heart Foundation, who all have a long-standing commitment towards cardiac rehabilitation. Now, the key message from their campaigns were incorporated into our Better Heart Disease and Stroke Care Action Plan that several members have made reference to, which placed a greater emphasis on the importance of proper support following an acute episode of treatment. Our action plan also recognised the wealth of evidence supporting the clinical and cost effectiveness of cardiac rehabilitation that several members have made reference to. The importance of cardiac rehabilitation is also echoed in Scotland's SIGN guidelines and the clinical standards for heart disease. Put simply, cardiac rehabilitation is an inexpensive treatment that saves lives. We want everyone who could benefit from cardiac rehabilitation to get appropriate access and ensure that they have the best possible chance of a full recovery. Now, we have been making excellent progress towards achieving this goal in recent years. ISD has reported uptake of cardiac rehabilitation for people with either myocardial infarction or a cardiac intervention has increased from 45% in 2006 to 65% in 2011. Equally impressive is the evidence that shows the high quality of services now being delivered in Scotland. Most areas already have a full range of psychosocial, health, lifestyle and medical risk management provisions in place, all recently highlighted within the BACPAR standards. And I know that the audit findings have triggered a range of improvement works within services, and I will want to see evidence of further improvements by all boards when further audit results are published later this year. But like BACPAR, we want to ensure cardiovascular prevention and rehabilitation services are safe, effective and also person-centred. The revised BACPAR standards emphasise the need for rehabilitation to be provided in a way that meets an individual's needs. This fits Scottish Government's person-centred approach to the delivery of healthcare, and it reassures that the recent audit found many NHS boards already offering a menu-based approach to cardiac rehabilitation. Now, the National Advisory Committee on Heart Disease has already identified cardiac rehabilitation as a priority. As part of our heart disease programme, we have supported the comprehensive audit of cardiac rehabilitation ever undertaken within Scotland. We've also provided some £20,000 of funding to the Angus Activity Programme for people with a long-term condition, and we have funded the development of an online version of the Lothian Heart Manual. However, there remains much more to do. Helen Eadie is correct in highlighting the clinical standards for heart disease are very clear that all people with heart failure and acute angina should be assessed for their suitability for cardiac rehabilitation. We know referral rates for these groups continue to be very low. Rehabilitation services in NHS Scotland are already working to address this through service redesign. They are implementing a menu-based approach, anticipating that this will enable an increased level of service capacity. And I would expect this work being taken forward by boards to make sure that it achieves improved outcomes for patients. We also need to look at the kind of rehabilitation services which can and should be made available for people with heart failure and unstable angina. Only a portion of heart failure and angina patients will be suitable for secondary care-based cardiac rehabilitation programmes. This is essential. It's essential that people with heart failure and angina get the support they need in their homes and communities. There clearly remains further scope for promoting exercise for people with cardiovascular disease and indeed other long-term conditions within the community, particularly within our leisure centres. There are already several examples of excellent programmes, including one in Lanarkshire, and I want to see this approach being explored further and rolled out elsewhere in the future. In terms of our next steps, Presiding Officer, I have asked our National Advisory Committee to consider at their next meeting in February how we can ensure people with heart failure and acute angina get the support and rehabilitation they need. Additionally, the establishment of a new heart failure group will support this process. The development of a heat target proposal for cardiac rehabilitation will be one of the options I'll ask them to consider. The revised backpass standards make clear the importance of an ongoing audit, and the enthusiasm in Scotland for the previous audit was extremely heartening. We have therefore explicitly committed NHS Scotland to the ongoing monitoring of the provision of cardiac rehabilitation in Scotland. A further audit will be issued later this spring. We have also provided substantial funding to Chest, Heart and Stroke Scotland and to the British Lung Foundation and to the British Heart Foundation in Scotland on a programme aimed at supporting people with conditions, including those who have heart failure and acute angina, to access appropriate exercise and support. And I expect to be able to provide further information to Parliament on this later in the year. Presiding Officer, I would like to thank the staff within NHS Scotland for all the work they have done to improve the care of people with heart disease in Scotland and to restate this government's commitment to supporting ongoing improvements in cardiac services, including rehabilitation services within Scotland.
Excellent. Thank you very much. And I now suspend this meeting of Parliament until 2:30.